Well, thank you, Dr. Go, Aggie, for asking me to give this talk today. Dr. Reber, who's chairing the session. I'm in a tremendously accomplished company, and I feel very honored to be the person to talk to you about the surgical management of pancreatic cancer in the year 2015. Outline about what we're going to talk about today are the current statistics of pancreatic cancer. Aggie and Dr. Go have already outlined them, but we'll review them again. Staging and surgical treatment of pancreatic cancer, and then spend the last part of the talk talking about the outcomes here at UCLA, particularly for patients who have more advanced tumors, which we have a particular interest in and are very, very proud of. To start off, first define pancreatic cancer, right? There are two cancers that can develop in the pancreas for the most part. Those are pancreatic ductal adenocarcinomas and pancreatic neuroendocrine tumors. We'll spend most of the day today talking about pancreatic ductal adenocarcinomas, which are the more common type of pancreatic cancer. They develop from the digestive-related component of the pancreas, as opposed to neuroendocrine tumors, which come from the islet cells or the hormonal part of the pancreas. The digestive part of the pancreas comprises about 95% plus of the gland, and the hormonal component is about 5%. I wish, as a pancreatic ductal adenocarcinoma researcher, that the NIH would appropriate their funding in that kind of ratio also, but they do spend a lot of money on pancreatic neuroendocrine tumors, which are also important. Anyways, as Dr. Go mentioned, pancreatic cancer is currently the fourth leading cause of cancer-related deaths in this country in year 2014. You can see lung, bronchus, prostate, and colorectal are the top four for males, and then lung, bronchus, breast, and colorectal are the top four for women. But again, pancreatic cancer is the number 4 cause of cancer-related deaths in both men and women, totaling about 40,000 deaths per year. As also has been previously mentioned, this number is on the rise. It is not a proud statistic, but the pancreatic cancer, in terms of cancer-related deaths, is rising from number 4 by 2020 is predicted to be the number 2 cause of cancer-related deaths after lung cancer, and this is because of an increasing incidence and also a relatively stable survival rate for pancreas cancer. The survival for lung cancer, breast cancer, colorectal cancer are all improving, and that is why these statistics are changing. Why is pancreatic cancer such a deadly, for the most part, disease? It's because patients don't really develop symptoms until they have more progressed or advanced cancers, and these are depicted here in stage 3 to 4 disease, which comprise about 80 to 85% of patients when they are diagnosed with pancreas cancer. As you all know, as well if not better than me, that pancreatic cancer is known as the silent cancer in that it does not develop or become associated with symptoms until it has become large and or widespread. And the increasing stage is associated with a decreasing survival. As the stage progresses, the survival goes down. Therefore, one of the main reasons why pancreas cancer is the number 4 and potentially going to be the number 2 cause of cancer-related deaths in this country. And it also is relatively resistant to most therapies that have been given. Aggie mentioned that we are focusing more on now molecular related therapies, and that is hoped to improve the response rates. The staging and surgical treatment of pancreas cancer, well, here is the anatomy of the upper abdomen or the foregut. The pancreas is hiding there behind the stomach by the first part of the intestine, located very close to the liver. And you can see here that where the pancreas is highlighted, it runs transversely across the abdomen in the upper abdominal region. I must give credit to Dr. Reber. These were his slides that I took, and I'll show you why I'm going to give you credit, because they're so neat and animated. I've heard that DreamWorks is not doing very well and are looking for someone else, and I really think he may be a good candidate. Watch this, right? So we have, this is an example of a tumor within the tail of the pancreas here. This would what we would consider a localized cancer in the tail of the pancreas. And this is considered a resectable lesion. So at the present time, a patient who presents with a tumor that looks like this would be recommended to undergo surgery or an operation first, and then adjuvant or postoperative chemotherapy after surgery. The tumors can also develop within the head of the pancreas here. Again, this is one that's confined to the pancreas, does not involve the vasculature around the pancreas. And the current standard of care at this point today, which may change, is that this patient, again, would be offered an operation first and then chemotherapy after surgery. Unfortunately, the pancreas is located close to numerous essential blood vessels, the portal vein, the superior mesenteric vein, which drains the entire intestine, the hepatic artery, which supplies the liver. These blood vessels cannot be removed without being reconstructed. The tumors in the pancreas, if they develop in this area, you can see that this one is also involving the portal vein or the hepatic artery. Unfortunately, this tumor could not be removed to negative margins, at least at the time of diagnosis. And rather than offering this patient an operation up front, we rather treat them with chemotherapy first in an attempt to shrink the tumor away from the vasculature such that it can subsequently be removed to negative margins, which we'll spend a little bit of time talking about later. Again, the hepatic artery and the portal vein are not the only blood vessels that are near the pancreas. For example, this tumor is located near the superior mesenteric artery and vein, and this patient also would be offered chemotherapy or treated with chemotherapy first in a hopes of shrinking the tumor away from those blood vessels and then undergo an operation. The location where pancreatic cancers form, this shows the distribution of them across the pancreas. A large majority of the cancers form within the head of the pancreas, 3/4 of them or so, which is the area of the pancreas that's located close to those blood vessels that I just talked about, which can get in the way of a margin negative resection, which is really what is the overall ultimate surgical goal. About 1/4 of the tumors develop within the body or tail of the pancreas. Unfortunately, those don't usually present until a little bit later because patients don't become symptomatic. The head of the pancreas has the bile duct going through it, and oftentimes the symptoms that first develop are jaundice because that bile duct is obstructed by external compression by the tumor. The American Joint Commission on Cancer has developed a staging system for all cancers, and this is the one for pancreatic cancer in particular. To simplify it, you can see stages 1, 2, 3, and 4, and I showed you earlier the distribution of patients when they present with pancreas cancer and the survival associated with them. But put simply, stages 1 and 2 are cancers that are confined to the pancreas, or they can involve the local veins, right? So the portal vein, superior mesenteric vein that are next to the pancreas. Stage 3 cancers involve the local arteries around the pancreas, the celiac artery, the superior mesenteric artery, arteries that cannot be resected. Stage 4 tumors have distant spread to the liver, lungs, etc. This staging system, the AJCC staging system, is not particularly practical. It is not what is routinely used in the preoperative or diagnostic setting. We rather use this system, which is more useful. Patients are, for the most part, staged into being potentially resectable, borderline resectable, or locally advanced, which are tumors that have grown a little bit too large to involve the local vasculature, or metastatic in those with distant spread. And it's because this staging system really is associated strongly with how we treat patients. Again, the potentially resectable patients are offered surgery first and then receive chemotherapy after surgery. The borderline resectable and locally advanced patients are treated with chemotherapy or radiation therapy to try and shrink the tumor away from those blood vessels to attempt a margin negative resection eventually. And metastatic patients at this current time are treated with chemotherapy, occasionally radiation therapy, and not surgery for the most part, overwhelming majority most part. but perhaps when chemotherapies do improve and the medical treatments of pancreatic cancer improve, then these patients may also be treated with some form of surgical therapy in combination with chemotherapy, but not right now. The resections that are performed for pancreas cancer, it depends on where the tumor location is. Tumors that are located in the body or tail of the pancreas are taken out with a distal pancreatectomy and splenectomy, which we will animate yet again in just a couple minutes here. Tumors in the head or neck of the pancreas are removed by a Whipple operation or a pancreaticoduodenectomy, which we'll more comprehensively define. Okay, so we're going to animate our tumor in the tail of the pancreas again here. And again, this is a localized tumor that it would be thought to be resectable. And this is taken out by a distal pancreatectomy and splenectomy. The dotted line that you see on the screen there is the area at the time of surgery where the pancreas would be cut, which is just to the left of where the tumor is located. And at the time of surgery, the pancreas is sent down for the pathologist to evaluate to make sure where it is cut that margin does not have any tumor cells present. If it does, well, we then take a little bit more and go to the point where there are no tumor cells seen and the margin is negative. What is circled here in green or blue, I guess, but it's got the purple. The pancreatic cancer purple is what is removed. Again, the tail of the pancreas and the spleen are both taken out en bloc. And this is a picture, again, that Dr. Reber made with the spleen and pancreas removed. And you can see our fine sutures at the cut edge of the pancreas there to try and make it sure it's watertight and prevent a leak from happening. Tumors that are located in the head of the pancreas are taken out with what is called a Whipple surgery or a pancreaticoduodenectomy. There are two main types of Whipple surgeries. There's a standard Whipple and a Pylorus preserving Whipple. In the standard Whipple, the distal stomach, the intestine, the gallbladder, the bile duct, the head of the pancreas are all taken out. It keeps us busy for pretty much the entire day. You can see that is what is outlined in the dotted line there on the left side. And on the right side is after the Whipple specimen has been removed, where the reconstruction has been performed, where the pancreas is sewn to the bowel, the bile duct is sewn to the bowel, and then downstream the residual remaining stomach is sewn to the bowel. The other variety of the Whipple surgery is a Pylorus preserving Whipple. This is where the whole stomach is left intact. Right, so none of the stomach is taken. It's the first part of the intestine that's sewn back to the jejunum there. The cure rate is the same with both Pylorus preserving and standard Whipple operations. Most resections done in this country, and a overwhelming majority at this institution are Pylorus preserving Whipples. It's the pros and cons of a Pylorus preserving Whipple versus a standard Whipple is a cheerful debate that's had amongst pancreatic surgeons, usually over a glass of wine or so. There's apparently this support group out there, I couldn't resist but showing you this, called the Whipple Warriors. Apparently, you can see they've got their own T-shirts. This is a picture of a patient of mine who sent me him in his Whipple Warrior T-shirt. You can see this is an email on the bottom right. Here I am with my Whipple Warrior T-shirt. So perhaps you may want to look at it if you had a Whipple. I've heard that the entrance requirements are pretty strict and I'm not eligible. The Whipple operation today, we've come a long way over the course of Dr. Reber's career. The safety now is really great. You can see that the mortality rate is significantly less than 1%, so it's very safely performed and recovery is almost usually guaranteed. The complications now are extremely well managed. Very rarely do we have to reoperate on patients after they've had a Whipple procedure, and if a complication does happen, they're managed with interventional radiology. Quality of life after surgery for patients is really very good. There are relatively few sequelae or long-term effects that can happen as a result of the Whipple surgery. Cure rates are good too, 25 to about 35%. So patients with early stage disease who undergo Whipple surgery, the cure rate for pancreas cancer in most large series is 25 to 35%. And cure is not possible without it. It's the only treatment modality that gives a chance for complete cure. Again, Aggie gave us a wonderful endorsement for our Pancreas Center here at UCLA, but we're really very proud of our outcomes. I think that we have technically mastered the operation here, but we've also selected patients really appropriately who will benefit from it. This is the 5-year survival statistics of UCLA versus our peer institutions, and we really, I think, are doing an excellent job and have really fantastic outcomes. After surgery for patients, adjuvant therapy is given. So this is the chemotherapy that's given after the operation, and the real rationale for it is to eradicate any remaining microscopic tumor that's not seen by CT scan, MRI, or PET scan, or even in the operating room with inspection. And we strongly and hope that all patients should receive that chemotherapy. Dr. Lee Rosen's going to talk about this a little bit later, but this is one of the things where a multidisciplinary program like we have in Aggie is supporting. It really ensures we have many wonderful nurse coordinators who can help ensure that patients, in fact, do receive adjuvant chemotherapy. Okay, so end our talk on our UCLA outcomes, but what I really want to focus on is those group of folks who have what we call borderline resectable or locally advanced disease. These patients, as I said, have tumors that involve the local vasculature and which cannot be removed for the most part, and are given chemotherapy or radiation therapy, and then ultimately, hopefully, given an operation. And we've studied them intensively because the treatment approach for these folks has really changed over the last 20 years. We want to make sure that we're doing the right thing. And bottom line, I think we are. So again, here's our animated tumor that I'm talking about here that's located in the uncinate process of the pancreas and involves the superior mesenteric veins and artery. And this patient would be considered unresectable because the goal of surgery, the only way that surgery really benefits or optimally benefits is if it can be done and have the tumor removed and have those margins be negative. So one might ask, why not resect the blood vessels up front? So if the vessels are involved, why not just take them out and put them back together again? Well, there's a lot of words here, but I think that they're all extremely important. I really did try and cut it down, but we're just going to go through it. So many of those patients with vessel invasion have extensive tumor with microscopic spread that just cannot be removed completely, right? This tumor is not seen on the preoperative scans, but experience tells us that it's really there in many cases. That is compounded with the fact that surgery with vessel resection, it's more extensive and it's associated with longer recovery time before the chemotherapy can be administered, which is really what is needed for that microscopic tumor that can't be seen that's probably outside of the area of the pancreas. And historically, when we started changing the treatment of patients with this stage disease at other institutions, those who underwent surgery and had vessel resection and had them put back together again, their survival was was about similar to those folks getting multi-agent chemotherapy. So that really told us that this is not the right approach for these patients. What we do at UCLA and what other centers have done after that initial experience was to give folks with the just locally large tumors chemotherapy and or radiation therapy in an attempt to shrink the tumor away from the blood vessels, and we give it for about 6 to 12 months. Here's an example of one of our peer institutions that give it for a shorter period of time, and that's really the norm. I'd say most institutions for the borderline resectable or the tumors that are a little bit too big give treatment for about 3 months. We like to give it longer, and I think that's the right thing too, and I'm going to show you why in a minute. So the rationale for giving this is to kill the microscopic tumor and make sure the disease remains localized. The last thing we want to do is give a patient an operation and resect a blood vessel, have them in the hospital recovering for a while and postoperatively, and then have them develop something in their liver shortly thereafter. That would tell us that we treated that patient wrong. But with this 6 to 12 months of chemotherapy, we're really able to observe the tumor and make sure that it is a local problem. And the chemo is effective on that local tumor also. We have a number of patients who have had the chemotherapy first, and then we've done surgery, and the pathologist tells us we can't even find a tumor cell in these tumors. So we're not losing ground on that tumor by leaving it in place. We're actually just, it's an all-benefit, no-cost scenario. Okay, after the 6 or 12 months of chemotherapy, we reevaluate by CT scan CA19-9, and then some patients are taken to the operating room. And I think we've found that about a third to 35% are able to undergo surgery who start out with this borderline resectable or locally advanced disease. And as I said, this has really been first reported by our group, predominantly Dr. Reber, in 1998. This is an example of what I'm talking about. This is a patient of mine. You can see he had a very large tumor in the head of the pancreas that was involving the local vein, the portal vein, the superior mesenteric vein. Patient underwent 9 months of FOLFIRINOX chemotherapy, and the tumor markedly shrunk and the vein came back. We did operate on him. We were able to resect his tumor to negative margins, and we had to take out part of his vein. He does have a recurrence, but he's alive 4 years later. So we have, as I said, we've critically looked at our experience with this, and we want to make sure that our survival is excellent, and we're doing the right thing for our patients. So if you can see this, as I said, this started in about 1998, and we've treated 88 patients, or operated on or resected 88 patients who have this locally advanced and or borderline resectable disease. This is broken up into all patients, and then the first decade where we only did 15, then the next 6 years we did 30, the last 4 years we've done 43. So we're doing it more and more. I think this is because the treatments are getting better. The percentage of patients who we decided, that we think that they would benefit from an operation, who we took to surgery, that we were able to resect is pretty high. It's very high. So we are selecting at least the right patients to take to surgery who can technically undergo what is hopeful margin negative resection. The median duration of chemotherapy, I said our peer institutions usually give about 3 months. We still give between 6 and 8 months. The median duration is 7.4 months, but again, much longer than the other folks, because I really think that this longer duration selects for the patients who will benefit from an operation. We're being a little bit more aggressive now, probably in hand with the improved chemotherapeutic agents. We're taking out veins and we're putting them back together. Not on everyone, only on people who we are as convinced as we can be will benefit from that procedure. So in this last 4 years, we've removed about 8 portal veins and reconstructed them. So about 20% of patients who are resected that go to surgery after this preoperative chemotherapy undergo a vascular resection and reconstruction. But our survival is excellent. If you see here, all patients, the median survival is 51.7 months. That's over 4 years. I think we have almost up to 50% 5-year survival, which is really, really, really fantastic. These are the right patients that need an operation. The most encouraging thing I told you is over time, we're getting a little bit more aggressive in hands with the better chemotherapeutic agents. But look at our survival in this last group. It's 48.9 months. That's the median survival. Again, over 4 years, and we haven't even reached the median yet. The survival curve has still yet to mature. So it's going to be longer than this. So very, very encouraged by that. If you compare this with our overall survival of potentially resectable patients who went to the operating room right away before receiving any therapy, this is about equal to those stage 1A or 1B cancers, which are really small cancers that are confined to the head of the pancreas. So we're able to get these patients who have treatment and undergo surgery into the same situation of those who present with a 1 centimeter tumor. So very, very encouraged by what we're seeing here. So what's the current status of pancreatic surgery circa 2015? Well, further major advances are really unlikely, right? So the mortality rate from the operation is less than 1%. So we've really optimized that component. The changes in techniques are not likely to increase patient survival, but the thing that's going to really help from a surgical perspective is the improved outcomes are likely to come from more effective drug treatments given in combination with surgery. And I think our locally advanced borderline resectable series really illustrates that for you. The treatments are getting better, we're being more aggressive in the operating room, and we're having outstanding outcomes to the point where these patients are living as long and doing as well as patients with small early stage tumors. Thank you very much for asking me to speak today, and thank you again, Aggie, for all your support for our center.
Tim, thanks very much. I think we have time for a few questions.
You mentioned the post-surgery survival rate of 5 years. Do you know what it is after that for patients 10 years after surgery?
No, we usually use the marker of 5 years as kind of the benchmark that's evaluated. Most patients who are out 5 years are clear. There are cases where we have seen recurrences greater than 5 years, but it's a great benchmark to get to. Yeah.
Just a quick question. I'm troubled with one of the lines in your chart. It said 25 to 35% cure rate after the Whipple. I guess I had two questions. Does cure mean no cancer for the rest of that person's life? And then why is there a range? It seems like the cure rate should be just one number.
So thank you for your question. The cure rate is really, we're speaking of for the most part 5-year survival, maybe a little bit longer than that. The reason why there's a range is because that range was taken from multiple studies that were done at high volume centers. So, as I said, here at UCLA, we're about 30%. But at other institutions, at UCLA, Johns Hopkins, MD Anderson, Memorial Sloan Kettering, that ranges from that range.
Tim, thanks very, very much.